Well, we get this set up. Thank you all very much for having me. It's an honor to be here with you again today. And to follow up on what was already said, the Einstein quote, my admonition to my students is always the word hubris, to be very careful of this thing. The thing that I fear the most in a hospital is somebody with high confidence but low competence. And nothing worries me more than that. So thank you for that. While we get this slide set up, I think this idea of innovation is very interesting. We've heard a lot of wonderful new ideas. We have people using AI to, think about how to improve patient care. But I think we have to be careful. Again, I think to this idea of decolonization, that somehow, these institutions, somewhere in Europe or in North America, somehow we have this figured out, and then we have the solution and we have the recipe. And only if you do it this way, your country will be just fine. In many ways, I hope you don't follow my footsteps. In many ways, I hope you don't end up with many of the problems that we have in North America. I hope you come up with something even better, right? And the idea of this word innovate is an interesting one, right? I think particularly where I live and work in the Silicon Valley in California, Google, Facebook, Apple, these technology companies, when they think of the word innovate, it's very different than how I think about the word innovate. If you look up the definition of the word innovate, right? What we're talking about is introducing a new idea, trying something new. Okay? But new to whom? Right? This has been a very eye-opening trip for me. I've learned so much on this trip. This too, like was my first trip to Bangladesh. It's been wonderful. I've tried many new things. But guess what? None of the new things I tried are new to you. But they're absolutely eye-opening and new to me. Right? So think about that. I challenge you to kind of let that sink in and to think about, what our esteemed professor shared with us. And let's talk a little bit about this and see if we can explore this topic together a little bit more. Right. So in thinking about what can I share with you that's new, that's innovative, and the journal clubs and things. I don't want to do this. I don't want to turn this session into me quoting you from, what I think are the best papers from the last year, done by a bunch of, white people in North America. That doesn't help us. Okay. But what came to mind that I do want to share was those sort of this very interesting work, an article done by Jenny Temmel, at Mass General at Harvard, along with some palliative care colleagues, Vicki Jackson, who were my seniors by 1 year when I was there. And is everybody familiar with this paper that came out this summer? Yes? Yeah. So this is sort of a follow-up study. We were kind of half joking about this the other day. When you get on the academic gravy train, you have to keep coming up with studies to kind of justify your existence in academia. The paper that made Jenny, all of you know, was the famous New England Journal paper looking at lung cancer patients, right? Where those with and without palliative care, and demonstrated both
study, the one at MGH.
The original study,
Yeah.
right? That was published, right? Now well over, let's see. So that would have been about 14 years ago, right? Over a decade ago now. Thank you. That was the seminal study, right? That really demonstrated the benefits, evidence-based benefit of palliative care in lung cancer patients, right? So this new paper, for those of you who have not had a chance to look at it, I'll summarize it for you quickly, right? And you can read for yourselves. If you can, I don't know. Is the quality of the screen's okay? Can you guys see?
Yes.
Yes. Good. Okay. Then I won't read to you. You guys can read. But the idea here is that they went back and sort of said, we know that this helps patients, right? But if we think about sort of, even where we are in the US, that there are pockets and there are places of the US where palliative care is limited. There are places like where I work. So I work in a government hospital in Palo Alto. And as a government hospital, different from private hospitals, we have patients that under government funding can get care from my hospital. Now, because of these patients and their financial status, they have to travel very far. They have to travel sometimes 2-3 hours to come to our clinics in our hospital. Okay? I think many of you in the audience here in Bangladesh can relate to this. Okay? Now, we know our patient population, right? These are people who oftentimes are facing some kind of life-limiting, life-threatening illness, right? We saw the slide earlier about symptom burden, right? It's not just pain, it's fatigue, it's nausea, it's all the things that we all know, right? And now you say, oh, don't worry. We have wonderful, smart doctors here in this hospital. Just drive 2 hours, right? Come see your doctor for 20 minutes and then drive another 2 hours home, right? Easy, right? No problem. No, it's very challenging. It's very hard, right? So what she looked at then was a comparison, right? And I won't go into the methodology and all that. This is not that talk, okay? But what she and her teams set out to look at was to sort of say, hey, what if we did sort of a more traditional model where people saw palliative care just as part of their standard oncologic care, right, on a regular basis, versus what they call sort of step care, right? And step care basically is, I think about it, if you think about sort of cancer patients, it's sort of a dose reduction trial, right? We used to give people this much chemotherapy to try to treat their cancer. Can we give them a little bit less chemotherapy and still get the same response? Okay. All right. So this is basically the study, right? We know a lot of palliative care helps these patients. Can we give them a little bit less palliative care and still get the same response? Interesting question, right? So, and this is a multi-center. I will say, I'm a little biased. I'm a fan of their work. I think they did a good study. I think they did a very good study. And what they found, right, is that, obviously the step care group, right, that had the sort of reduction with certainly timed and marked visits, right, when there was changing prognosis, changing diagnosis, increased symptoms, then you come see your palliative care team. That there was a significant, right, fewer visits. But the interesting thing, right, is that they did just as well. The one area was that the hospice use was a little bit less. But from a symptom management quality of life standpoint, they were matched. Okay? So what's interesting here is that, given sort of the limited resources in many settings, right, and the challenge of providing care to our population, even when your resources aren't that limited, right? I'm a very well-resourced hospital, right? But just because I'm well-resourced doesn't necessarily mean that my patients and their families are always well-resourced, right? So we have to take all these pieces into consideration, right? And so this, to me, was a very interesting study that is a little unconventional, I would say, in palliative care. And that's why it caught my eye. And it's an interesting study because I like things, as I mentioned earlier. At the end of the day, I'm a clinician at heart. I became a doctor to take care of patients and their families. And that is still, I love teaching. I love the research. I love all the other things I get to do. Don't tell too many of my colleagues, but I actually enjoy some of the administrative headaches and the running of the service. But this kind of study really speaks to my heart because it puts me back to the root of what I do and say, then if I have to innovate if I have to think about something new that I can do in my hospital, my clinic, to better take care of my patients, what might that look like? Right? And I say this both to me and as a challenge, as a question to all of you to say, hey, and listen, AI is wonderful. If you have the technology resources to explore those things, by all means, right? But be careful of that trap that these innovative new ideas doesn't have to be something that no one's ever done before, right? They just have to be new to you and your patients. And if they work, how wonderful is that? Right? So, when I think about improving access to care for my patients, right? So this is now a very interesting proposition, right? Right? How do I do more, or rather maybe better provide more, or provide for about the same, right? If I can do less, right? If my resources are constrained, right? This now is a very interesting proposition idea that how do I help these patients and families, right? And when I think about this in my context, right, as we were talking about this in my team very recently, then, so these are some of the things. I'm not saying these are the things that you have to do, but this is the conversation discussion that's spurred within our group. And then if you indulge me, I'll take just a couple minutes and I'll share them with you, right? We're thinking and talking about how do we utilize our volunteers. Right? We're fortunate to have sometimes students who have some time and they think this will look good on their resume. It's a little bit Machiavellian, but I'm not above taking advantage of such things. Okay. Right. We are fortunate sometimes that in where I live, we have some retired people who have some time on their hands and they're kind-hearted people that want to give back some of their time. Great. How do I use these people? Right? How do I use other than doctors and nurses? Because even for us, they're very expensive, right? And it's very difficult to get a doctor's position to open up at my hospital, let alone, and that's before I try to fight for a tenure track professor position. That's even harder, But turns out I can hire other team members at a much cheaper rate, right? And if I can do that, how do I leverage that for my patients and our team's benefit, right? How do we think about active case management and think about Jenny's paper, right? Then how do I manage that? If that's a benefit to my patients, how do I utilize the stepped approach to our patients and their care, right? And I just got some new ideas. I'm going to go back and talk to my people about, if I don't have to hire a case manager, I can have AI do it for me. We'll be talking. Okay. All right. He's my new consultant now. He doesn't know it yet, but he's my new consultant. Okay. All right. And we have these wonderful embedded clinics that is one of the newer things that we started doing within the last year and a half, is that our healthcare providers and oncologists see patients together now, right? And this is a long time in coming, right? This did not happen. So this happens because it's one of those things when you've been around a place long enough for over 20 years, like I have, and my student is now the chief of oncology. It helps a lot. It changes the dynamic. It changes the relationship, right? And now my student, who's the chief of oncology, very smart, very bright, brilliant woman, she says, Gary, I think it'd be great if we do this thing that you've been talking and you taught me about this. I said, yes, let's finally do it. It's been too long. So it's taken us this many years. We just started this last year and it's been wonderful, right? And conceptually, it makes sense, right? We don't say to patients about to have surgery, sir, you're about to undergo surgery. Would you like to have an anesthesiologist? And after surgery, would you like to have some rehab, perhaps? No, right? If you're going to have surgery, guess what? You get an anesthesiologist along with your surgeon, and we plan for post-op care and we plan for rehab. So how do we innovate? Right? I mean, the point here is, people make innovation sound like it's some brilliant, eye-opening, the skies open up and the angels sing and the light come down. No, right? It does not, my point here to you all is when we think about innovation, right, it does not have to be that, right? Okay. And so for us, this embedded clinic concept has really helped grow our program. And more importantly than growing the program is that it's really helped the patients. Because guess what? Some of these patients do drive 2-3 hours to come see their oncologist in Palo Alto, right? But now they can also see their palliative care doctor on the same visit. They don't have to come back a second time, right? Now, another 4-hour round trip. That's a burden. So this is good patient care, right? And when we can, we've been implementing since COVID much, much more telehealth and virtual visits. And it works very well, right? And so these are the things that, again, these are not new ideas for many people, right? But the message here is I want all of you, and as I said yesterday, to think about how and what works for you and your context and what is new to you and your patients that you can try it. Thank you very much.